overview from few researchers I've consulted. It's not my regular work. So, as outlined, I would like to share with you the method of biomarker analysis, predictive biomarker in oncology, the challenge in delivery, and as a conclusion. Here, I go directly to the method of biomarker analysis. As you may know, there is change in DNA sequencing, change in gene copy, and MLR transcription. You have here DNA mutation analysis. We can make, some analysis through FISH or CIS or microarray and RCT PCR, and then the next generation sequencing. MRI transcript conduct protein secretion synthesis. Those proteins are detectable by immunohistochemistry, but also you have biological activity, oncogenesis, drug target. Here you have an example for anaplastic lymphoma kinase biomarker, where you can see here the result from FISH, but here again different PCR alkaline fusion gene transcript. Here immunohistochemistry for L-key protein. Prognostic and predictive biomarkers are used to guide treatment decision in oncology, as you may know. We are, as pathologists, providing some information on outcome independent administrator therapy, and the predictive should be provide information on outcome with regard to a specific therapy. Prognostic biomarker may help define patient prognosis, risk of recurrency, patient prognosis, risk of recurrency of the duration of survival, predict biomarker, estimate response, or survivor specific patients. Here I can show you some biomarkers already known with some genes. Biomarker for immunotherapy had been discussed, and here I have some example. You see here different stains with PD-L1 negative, PDR positive, predictive of response, and down there you see the percentage of cells who are positive. The expectation is that several therapeutics should be done or accompanying according to several companion diagnostics. Here again an example of some markers in solid tumors. You see here in lung cancer, colon cancer, melanoma, and esophageal gastric or breast cancer. Personalized approach to treat cancer may be understood as the molecular basis of cancer has identified specific drivers and allowed for sub-classification of disease, revealing the potential for target agents. This is a situation we hope to be advancing. Administrator drugs as personalized therapy. This will depend on oncogenic target that derive cancer growth, predictive markers that detect presence of the target, if there are well-conducted clinical studies to confirm treatment efficacy in identified patients. The challenges are the reliability, accurate, timely, relevant, and cost. Here, you can see are the pre-analytic phases. Particularly, we have to use formalin fixed paraffin embedded tissue to check DNA for mutation. Depending on DNA quantification, if the single test can give enough positive, or should we look for multiple tests? Here see the rate of positivity. Accurate, is the test outcome correct? We have false positive tests. It means there are some contamination, or false negative tests depending on DNA quantity, DNA purity, enough for multiplex testing. Those are some questions we have to look. And then before we expect that really immunohistochemistry, biomolecular heterogeneity will help. Timely, how quick do you really need the result? More tests, more complexity, communication, patient, physician, lab physician, patient. Relevance, what are the biomarker tests needed? Has the lab performed the correct test? Cost, as you may know, technology, manpower are not cheap. Companion diagnostic are again not cheap. Pathology and therapy need budget and reimbursement. So the challenge we are facing in the era of personalized medicine, according to our practice in assessing morphology assessment, should we now have a range of biomarkers according to molecular diversity, testing complexity, sample limitation, and cell-based delivery? As you know, in our practice, we are doing histological classification according to immunohistochemistry, completed by novel CT method. And pathologists may be an integrator of information data. In this era, to produce novel pathology report. Here, this is our puzzle of histology activities. And then, according to what I have said, we have to look about physician education, build commitment through education of community physicians, publish new personalized practice guideline, which will allow us to have tests which really can help. Data integration according to electronic health records, and policy needed where pathology should make advocacy for reimbursement of the cost, and also regulatory options that encourage diagnosis and drug combination. Here, we are going to embrace era of diagnosis for improved outcome. As this is a slide, like a conclusion, I would like to thank you for your kind attention.